Hello class, Dr. Hawley here. Hello class, Dr. Hawley here. First of all, thank you for joining us. This is going to be Module 1 out of, I believe, 5 or 6 modules, and they're going to be quite lengthy. Each module, as you guys know, is going to have several videos with this attached. So we have a lot to do. So welcome to class. So most all you guys here have my email or both of my emails. During this here, my staff and I are going to be very attentive to those and answering questions, because some of you guys, this year is going to be a transition out of a wellness type practice into more of a evidence-based. And a lot of you guys have written me in the past and said, you know, we want to do this. How do we do it? Is there going to be a certification for it? Is there training? How's this going to work? So that, and then with the NCBTMB and I talking over the last, oh gosh, year or so about putting something like this together, we finally got it worked out, and this is what we're doing. So congrats, you guys are the first class that's running through, and to be honest, we have a lot of classmates here, so there's a lot of people on these. So what's the best way to do these, and how do we tackle this beast? Well, some of you guys I know are very, very busy with practices, so you're only going to be able to watch 1 or 2 of the things a week, which is fine. So it's going to take you, obviously, longer to complete the course, which is okay. There's some of them on here that you're in between practices, or you're not working now, or you have other staff that's working for you so you can do things. Hey, dive through these things. There is a ton of videos that we're going to be watching. Basically, what this has been done is a lot of my videos in the past, NCBTMB, is allowing me to bundle them because they are so medically massage oriented, they said. They're allowing me to bundle them as a package and create one overall huge certificate of achievement package for medical massage therapy, and they're allowing us to call it medical massage therapy. So, and they're going to recognize that. So as we're going through this, there's probably going to be 30 plus hours of CEs that they're going to go through and approve on this. So a lot of you guys have taken my courses. It's going to be it's going to be some of the same slides. It's going to be some of the pretty much the same things, but with a little bit more twist and a little bit more, oh, lack of a better term, congruency toward medical massage. It's now we have a gear that we're gearing it for. The ultimate certificate here for the MMT. So it's going to be geared for that. So some of you guys have taken my practices. You're going to recognize the slides. I'm going to redo every single one, which you guys know there's a lot of them out there. So that's what these modules are. So you're going to be getting these. And I know that, you know, the ones that have taken a few of my courses, you get to have access to all of them now for pretty cheap price with a good certificate at the end. So hopefully you'll enjoy this. It's a lot of work on our part. My team and I, we've been putting these together, getting them ready. So again, we decided also on the best way to do this. Instead of just giving it in one big lump, we're going to do it in brackets. So we broke it down into modules, mod 1, mod 2, all the way and so forth, and we're going to release them on different days of the week throughout the next 4 weeks. And that way it's easier for us to also keep track of who's watching, how far you're going, and to answer emails. And I'm going to try to fit in there a couple live webinars that's not included with the thing. We're just going to throw them in as bonuses. We're going to go over some live case correlations. So if you guys have some cases that you want us to go over, send them an email. Let us know about them. Let us know what you did, what it's going, or if a new patient presents with XYZ, send it over and let's discuss it as a class. We'll keep, you know, anonymity. We'll keep your name and everything else quiet. No one will know who submitted it. We will, you know, animosity. We'll definitely honor that. So, but other than that, let's go ahead and get beginning. So you're going to hear me taking little sips every now and then of water to keep the whistle wet. So this here, Module 1, we decided how are we going to do this? What's the best way to start this off? So we didn't want to just jump right in. So we figured the best way to do it is talk about what an evidence-based practice is. And I had a webinar, year, 2 years ago I did on establishing a EBP practice, and we've taken a lot of the things from that and we've applied it to this. So a lot of you guys, as I said, have written in after signing up saying, you know, I have a wellness practice. How do we transition? Well, this will give you an idea. It'll also give you an idea what is needed to be considered a EBP type practice, okay? So let's go ahead and move on a little bit. Maybe. Let me get this thing here working. There we go. So transitioning into, you got to have what I call three things, basically. The best research. You got to be able to have access to research, and yes, we are going to take our 3-hour research course and add this to this course. So those of you that did not take our research, guess what? You're going to have 3 hours of proved credit research. I don't remember which module it is in, but you're going to have that. You also have to have expertise. And again, I think all you guys here that are on this, especially the ones that have taken our courses, are really geared toward the MMT type practice anyways. And you also have to have good patient values, meaning you got to be able to select the right clients that are coming in. We're going to be viewing things now from a spa, a relaxation thing, for more of a condition-based. So you're going to be attracting those type of patients. Now, I always get asked, what's the best way to transition some of these things? We've helped a few over the years transition. You can have block segments where, say, if you have a wellness type practice now where they're coming in, they're doing just general relaxation things, you're doing energy work, you know, they don't have a just general condition that you're trying to get from point A to point B. It's a relaxation, stress relief. And you want to transition into more of a condition base. Well, you can block segments of time, say Monday, Wednesday afternoons, where you only do condition-based type practices, and still keep your other ones going, okay? So you can split it up like that. You can also stagger them throughout the day. Every odd hour of the day, you do an EBP one. There's many ways to do this. Now, the other thing I get asked, can we charge more? You know, that depends. I don't know if you could charge more, but the treatment plans, as you see, are going to be drastically different. It's not going to be a 60-minute massage once a month. It's going to be broken up into like 30-minute segments, multiple times a week. It's going to be a regular care plan, and we're going to get into those. And I think even in these, I have a couple examples of generic care plans I'll show you. What we're going to be learning how to do and set people up, and what type of patient responds better to what type of care plan. So that there's what I call the triangle of continuity that we are going to be going through. So let's keep that in mind as we go through this. Some of the definitions of the EBP, basically Sackett et al. Defined as a conscientious, explicit, and judicious use of current best evidence in making clinical decisions about the care of individual patients, okay? Well, that's fine, but really what does that mean? Well, that's kind of what we're talking about. We're going to be getting the best evidence, backing it by solid, updated research, and we're going to get into research and later on how to sift through and how to define that. That's a 3-hour one we're going to do. And then the other part of the triangle, getting the right patient for the right type of modalities and treatments we're going to be doing, and then your expertise. We're going to go over all working knowledges based on condition based. So that's what they're talking about us doing. So those are some of the definitions that they're talking about, basically just breaking it down. Now, the other way you can look at it too is that an evidence-based practice is basically establishing this as a process by which clinical decisions are made. And you have to be able to make prudent clinical decisions, again, based off the research, expertise, and patient preference. So you can't, it's a three-legged stool. I was going to say, you can't just have two of these and really consider it to be an evidence-based practice. You got to have all three in there, okay? So, and I don't want to dive on that too much anymore. Again, evidence-based massage basically is a treatment, provides massage with the interventions and intentions with a goal of achieving a specified outcome. Again, I can't stress that enough, because even after we did our evidence-based massage, I still got emails asking, well, how does this fit into a wellness lifestyle? You're going to be getting a different crowd of people. Normally the wellness lifestyle is the people that are doing pretty good and they want to come in for just, a little muscle work or stress relief. They're on the right side of the spectrum. We're going to be working with people now in this course on the left side of the spectrum, the ones that are post-surgical, post-auto accident, post-workers' comp, rehab, and ones with sciatica, torticollis, severe trigger points, fibromyalgia, specific condition-based that we will ultimately transfer into a wellness practice. Okay, so not every wellness patient will be a clinical case patient, if you know what I mean. But every clinical case patient, which is based on outcome practice medicine, massage, every clinical case will become a wellness case eventually. So we'll transition them into that. So don't worry, you're still going to have some wellness cases. It's the same thing with the easiest one is the chiropractic clinic. Patients will come in for a maintenance adjustment, but the practice wasn't built or maintained on that. We also had a huge condition-based practice. Every condition-based we transferred in to the wellness base, and that's what you're going to do here. You're going to have the condition base coming in, you're going to set up the programs, and once you get them through the programs, and we're going to walk you through step by step, then you'll get them into the wellness. So that's how we're going to transition this through this course. Now, with this, we got to go through some basic structures. We got to understand the musculoskeletal, neurological, and systemic. That's how this course is going to be defined. So again, neurological is impaired sensation secondary to entrapment. Okay, neuropathy or nerve root compression. Pain is also another thing that's neurological. Musculoskeletal, abnormal NMS tone, spasticity, rigidity, clonus, things like that. You can also throw in there biomechanics or basic posture abnormalities. Again, will affect the musculoskeletal. Systemic. This I also broke it down because you can deal with a torticollis, which is a combo neurological musculoskeletal condition that's isolated in the cervical region and the neck. That's not a systemic. Whereas diabetes, arthritis, things like that are what I consider systemic. Even though they have certain organs like diabetes, we're dealing with the pancreas, the islets of Langerhans, and some other organs, and possible thyroids and other endocrine things. Those are, even though we're dealing with organs, it's still what I consider a systemic type condition, just like fibromyalgia. So we're going to break this up into 3 different things, okay? Now, again, this year I put in, I forgot I even had this slide in here toward the back. I would have mentioned it. Just for you visually guys, visual ones that learn from visual, we have our wellness model. We're going to this year is into the condition base, okay? Both of those are is 2 different animals, okay? And I guess I just wanted to hit that home pretty hard with you guys when I was building this. You can have 2 separate practices within the one practice, okay? That's actually how my wife did hers in her therapists that were in her with her studio. They had all the bodybuilders, powerlifters, and then the ones that me and my doctors would refer, and then other doctors through town, all referred in clinical cases. They were condition-based. She also had a huge wellness following that they would do just general couple massage. They do Valentine's. They do, birthday things, just general wellness, stress relief. She actually did Reiki and energy work. She used crystals. She did a lot of the energy and general wellness massage, okay? So rest assured you can have a condition-based and a wellness, okay? I want to hit that pretty solid. Now, if we're going to be doing some outcome-based massage, we got to have, what I call SMART. S-M-A-R-T is the acronym for specific, measurable, action-oriented, realistic, and time-bound. Now, if you haven't heard of that before, I kind of put a spin on it geared toward our MMT here. What we're talking about is basically specific. It has to be geared toward the condition we're treating. Meaning, if we're dealing with a torticollis, We're not going to focus on stretching the low back or doing things with the feet, okay? That's going to be secondary. So if we come up with a treatment plan, we're going to gear it toward the condition that we're treating, okay? Got it? Now, you have to also blend with the overall goals of the client and or the care team working on the client. So if I referred you a patient, say we bent over at a factory to pick up a pair of pliers and we threw out our back and now it's causing a spasm, it's causing a peripheral entrapment, causing pain to go down the leg. So I'm going to be working structurally on getting the patient adjusted, maybe looking at some disc work, and then possible rehab. When I throw them over to you, I want you to be able to assess and do a little exam and come up with a care plan that is designed for that specific need. I don't want a wellness plan, okay? And I will go over what my goals are, and your goals and care would match mine, and that's how we do it as a care team, and we all work on the same page. That's how, in our clinic, in reality, we did it for years, and it beautiful. Okay, it worked beautiful for us. So whenever you're working on a client with another care team, make sure that your goals blend with theirs and share them and send the notes back and forth. The other thing, too, make sure also the goals of the client. So if we have a 80-year-old patient that fractures her hip and you're doing some work on tissue restructuring and getting some mobility in there, your goal is not to have them climbing Mount Everest. So make sure the goals are, for what they want to do. Now, you also have to provide a clear path to get the client back to where they were before the condition presented. That's another thing, too. It's very important in the history to find out what their activities were before said incident. If they could only walk a quarter of a mile without causing an increase in pain, or they could walk around Walmart to do their shopping without pain, great. Then your goal is to get them back to whatever it was before the condition presented. That would be your goal, and then that would be your long-term goal. And then you would break it down into smaller goals after that. And same thing with whatever the goal may be, whether it be sleeping 8 hours or whatever. Now, again, I alluded to it a little while ago, it must be relevant to the client. If we have an 80-year-old person with a hip fracture that we're working all the soft tissue around in, we're not going to, our goal is not to have them climb Mount Everest in 12 months. It's got to be relevant to the client. Now, I guess with that being said, if we have one of these baby boomers that's really out there that they are climbing mountains, then hell, that needs to go in your notes, and that's what you need to shoot for, okay? The goal with this is it's got to be specific to the client, and it's got to get them back to at least whatever they were doing prior to incident. Now, obviously there's limitations that matter, so if they have a really severe incident or condition that's going to prevent that, then we do the best, and that's called MMI, Maximal Medical Improvement, MMI. And then we would put in our notes, our MMI goals are blah, 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 okay? So that's what we do on that. Now that's the S. Now the measurable, we got to measure these things. To be evidence-based, we got to be able to measure. So they have to be actually physically measured, whether it be a tape, say they were or a goniometer. We're measuring range of motion, okay, or gait distance with tape, posture, high left shoulder, anterior rotated head, things like that, posture, balance, be able to balance on one foot, things like a wobble board. Timed events, again, walk in Walmart, how long can you stand without causing pain, or sitting without causing pain. Again, set goals and benchmarks. So we're able to walk around Walmart for an hour without causing an increase in pain. Great. So what we're going to do is over the next 2 weeks, we're going to get where we can walk for the next half of Walmart without sitting down. Then over the next 4 weeks, our ultimate goal is to walk all of Walmart without having to sit down. That would be our goal with the benchmarks in between, okay? Always ask when we're doing condition basis, how's your pain scale? What are you on 0 to 10, okay? Now I know that is going to be more subjective, and it is subjective, but we still gotta, that's a good documentation, and I think I have a visual analog scale here that's going to be in here that I'll throw in there that you guys can print out. We actually printed them and handed them out whenever the patient would come in. Now, action-oriented, This is the A part of the SMART. You have to provide physical evidence of improvement. You know, Medicare would pay for people to come in and see us as long as they were making some form of improvement. So we had to have goals. We had to give evidence that they're reaching the goals. We had to show a decrease in pain. If there was an re-exacerbation of pain, we had to show a new care plan, what we were doing to get them back to where it was, things like that, okay? So I'm not saying just to make sure you're getting paid. This is just in general. You got to show that you're making some level of improvement. And it's good to have that, because if you're wanting the patient to come in, a client to come in for 2 times, 3 times a week for a couple of weeks and then transition them into wellness, you got to show them that it's good to document and have this proof that you are making, you're chipping away at it. You know, the old saying, how do you eat an elephant one bite at a time? You're showing them what each bite is. So it's good to document and have physical evidence of this. You know, maybe Mary couldn't bend over to tie her shoes after the incident with her low back. But now Mary can bend at 30 degrees, and we're working her up to a 45 degree. And you measure it every second or third visit, okay? And you're showing and documenting. Now, one thing to keep in mind is whenever you're doing an action plan, you got to have goals, right? The end goals. The goals should still be the same, but the plan must be dynamic. The plan must be changeable. For instance, say if you have a goal for Bob to be able to go on his boat fishing for half a day, but Bob can't stand up for more than 15 minutes, and he can't walk on an unlevel platform. So we got to work on balance, strengthening muscles, and get some other things going. Well, as time goes on, you may be working with the hip flexors, the gastrocs, and trying to help with some proprioception by having Bob stand and just see how long you can do on one foot, eyes open versus eyes shut. You know, I know it's not in your wheelhouse yet, but I'm going to show you some tools that you can use later on. Now, what happens if Bob can't do any of those? Or every time you get on his hamstrings, you're starting to do some muscle stripping or ART, and it exacerbates everything. Well, that's when the plan might be changeable or dynamic. You may have to alter that and may do some advanced forms of ART. May need to do some kinesiotaping for a week or two to work him up through that. That's what I mean by the goal can still be pegged right to the wall, but the road to get to the goal can be changing. And I applied that to the clinic system because I believe that is a life thing in our life, whether it be finances, house, mind, body, spirit, whatever. We have our ultimate life goal, but the route to get there is always changing. Same thing with the clinic and the care plans. Let those be dynamic, okay? Because everyone's made different, so you may have to change some things. I know when we started doing some decompression therapy for low back and neck for the discs, we started adding in massage and ART, PNF, and then rehab on some of the patients. We were doing them 4 days a week. Well, some of them were getting re-exacerbation. It wasn't time to heal. What we did, especially the elderly, so what we did is we bumped it down to a 3-day a week instead of a 4 or 5 day a week plan. Had them come in on Monday, Wednesday, Friday. So our goal was still the same, but the plan of attack altered based on the client. Same thing as what I'm talking about that you may do, okay? Now, also the patient must be involved in the treatment. I found people, if you involve them with a treatment plan, give them some sort of authority in their care and some responsibility and make it known. And we all know it's the patient's, it's a marriage. It's half their responsibility and half yours. But that's supposed to be an unwritten rule that, unfortunately, a lot of patients never bothered to read. So they think it's all on you. Right up front, you say, all right, now, Sue, here's what we're wanting to do. You've been in an auto accident. You got a lot of torticollis. You got whiplash. You got a straight military neck now because of this. So I'm working with this doctor and this therapist, and I'm going to provide all the soft tissue work. And here's our plan. We're going to go 3 times a week for the first week, and we're only going to do half-hour sessions. And then we're going to do the second week, we're going to do a little eval, maybe bump it down to twice, and we're going to keep going and going. But during this time, I need you, and here's a list of home stretching that I want you to do in between these visits. And you got to do them because that's going to help me with these. I want to help you, but it's a marriage. We're in this together. So I'm working with the other team. That's what I mean about having the patient involved. They may do light stretching exercises. They may do laying on a rolled towel to help remold the cervical. They may do a contrast hot and cold shower on the back of the neck to cause hydrostatic pumping of the blood vessels. They may do that. So there's a number of ways that they can be involved. Okay, and you can also let them know, say, hey, I'm going to do this stretch and this new technique on you. I want you to go observe. Let me know the next day how it did. If it was super sore or if you increased motion, but it was sore, let me know. Give me feedback and get them involved. You'll find that they'll stick with the plan a lot more, and actually they'll get better recover. They really will. Realistic. This is the R of the SMART. The patient has to be able to achieve it, right? So like I was saying, the lady with the climbing to Mount Everest, right? So it has to be realistic. Make sure the benchmarks and deadlines for the benchmarks. There's goals, then there's benchmarks leading to the goals, then there's deadlines for the benchmarks. So say, Bob just had a hip replacement and your job is to work all the soft tissue around it. Don't put Bob running a Boston Marathon in 2 months, okay? That's not realistic. So they got to be realistic on this. Again, they got to be applicable to the patient's condition and lifestyle. Okay, that's what we've gone over that. And it must be fitting with the patient's condition. Hip surgery. I'm talking about Bob and his hip already. Same thing. If we're going to be doing dealing with Bob and a hip surgery, hip replacement, and he's a couple weeks post-op, and you're in there trying to get some range of motion and stretching, you got the baton handed you from the physical therapist. Says, hey, I want you going in, start doing J strokes on the surgery. Incision sites, I want you to start working some of the other muscles because they're overworked on the opposite side because we've been favoring the hip on the left. Now the rotators in the spine and the ilial, the pelvic muscles on the opposite side on the right are all in spasm. I need you to work on those and get them where they're pretty well evened out bilaterally. Okay, so we're not going to work on the neck or take time with the feet, things like that. We're going to focus on the condition. And once we get them bilaterally evened out, then we can start bringing in the other areas. And as we bring in other areas, we still monitor that conditioned area to make sure that we're not getting exacerbations, okay? So that's what I mean by it must be fitting with the patient's condition. Again, time bound. When we're doing the evidence-based practice, we got to have a starting date and an end time. Now, I know we can't guarantee this with the people. I know we're just practitioners, even doctors. We're dealing with life force in the human body. There's in nature, okay? But we got to have a guesstimate based on evidence that's out there, based on our expertise, and based on the type of patient that we select. So that again goes back to the triangle in the very beginning. So is a person that had a knee replacement that's a 120-pound female going to recover quicker than a knee replacement that is 300 pounds? Well, obviously, yes. What about two 120-pound people that have a knee replacement? One is a at-home mom that does things on the internet, and the other is standing on her feet all day at an assembly line factory. One's going to have a lot different care plan than the other. So you need to change your time and your benchmarks according to the individual. Must have re-examinations. What I mean by exam is we're going to get into this into the next module, but with the exam is you got to have some form, and maybe exam's too harsh of a word. Maybe we'll put assessment, initial assessment, because in case some of you guys don't like that term, but when I say exam, this is what I mean. The first evaluation, assessment, analysis, you got to have those. So say if I sent you a patient that hurt their back on the assembly line and they could only bend at the waist about 15 degrees before it starts hurting. And all you do is take your goniometer or even eyeball at about 10-15 degrees, and that's all they can bend. Great. So we set up a program for them a couple times a week for 2-3 weeks, and we're doing things. About every third to fourth visit, have them stand up and do another assessment. Hey, Great. Maybe they're bending 20 degrees now after one visit. Great. Maybe the next visit they go 25 degrees. Say the third visit they only go back to 15. Well, that's a clue because you've been doing a little analysis, assessments, examinations throughout their care plan. Now you see they regress, and then you hold the phone. Hey, Bob, what'd you do last night? What'd you do between last visit? We had a nice line, graph line that we're increasing, and all of a sudden we went back. What happened? If you weren't doing little mini exams or mini assessments, you wouldn't know how the condition is responding. It's a good check mark to do these, okay? How often? Chiropractically, and when we were doing our massage in our clinics and we were billing insurance for these, we had to do them every 12th visit or 30 days, whichever came first. And again, we had some major ones. For massage, where 90% of you won't be billing insurance and they won't be as severe conditions as we would see up front, I would probably do about every other to every third visit. Every second to every third visit, I do a little mini re-exam, whether it's a posture, just a gait, even, a blood pressure, something simple to keep an eye on things, okay? Now, we have to have benchmarks, and you can tell them, say, Bob, you're increasing your range of motion by about 5 degrees after every visit, every muscle stripping and stretching we do. So based on that performance, in 2 weeks, I'm wanting you at 45-degree angle where you can bend down and tie your shoes without pain, okay? That's our benchmark, okay? And again, as we go through this, we can't keep Bob coming in with 3 times a week forever or 2 times a week forever. We got to transition them into a wellness or a maintenance eventually. So we got to show decrease in frequency. Now, we understand that at times there is times when they'll get an exacerbation, and we'll have to extend that, which is very fine. But we have proof, we have documentation. Like I said, he was doing 20 degrees. Now he can bend this 15. If we didn't do our mini exams, re-exams, we wouldn't have that. Okay, and that's good evidence to show the patient. Just say you're doing cash only, you're not dealing with insurance, where you don't have to do this. Well, I beg to differ. You still do, because you can show Bob this. Bob is your insurance agency. He's the payer, not a third party. Bob, we've done this and this. Now, you know what? I was going to bump you down to once a week, but man, brother, you regress back down. You're only 10 degrees again. Let's do 2 more times this week. We'll get you back on the road, and then we'll start decreasing it down again. But I gotta have you doing things where you're making improvements. Okay. And again, you got to follow up with the maintenance. Once you get them through where they can reach the 45 degrees, then you put them on a maintenance schedule. Okay, that's where they come in and they maintain it, because there is a condition. It's always going to be a weak chain or a weak link in the chain. It'll be a weak spot. Okay. Some of the clients' goals, I get asked this a lot. What is some goals? I've never done this before. Well, here's just a list of things. I won't read them all off to you guys, but it'll give you some ideas, okay? Now, again, there's short-term and long-term. So short-term are basically anything that the client is used to doing and did on a regular basis prior to the injury. Make sure these goals, try to not make them all subjective, because you can't really measure those empirically sometimes. It's really hard to. The closest thing is the VAS. Pain scale. So try to make them objective. And again, have them involved where they let you know how they're doing on their goals, okay? You can't obviously measure if they can pick up their grandkid or if they can walk around Walmart. They can tell you that. So, and you document that, okay? Again, make sure you're documented in the notes what they've done, how far they've done. That way, because if you have 20, 30 clients a week going through this, and I know a lot of you guys are thinking, man, there's no way I can do 30. Well, yeah, you can, because you're only going to be doing, with the care programs, a lot of them, little 30-minute mini ones, so you can cluster them all in. Okay, so you can, and it's going to be hard to keep track of all these things, so make sure you take good notes. Massage for wellness. Once you transition from this, always remember they had the underlying condition that brought them to you, okay? So what I mean by that is a person can have a high level of wellness even though they have a medical condition that leaves them in suboptimal health. So say they have a hip. They're always going to have pain in the wintertime because it gets cold. They may have developed some arthritis around that, so they're always going to have a condition, okay? But overall, they could still be very, very fit. They can still have an overall level of wellness, such as chronic illnesses even, okay? They're still able to have a high level of wellness, and you need to work toward that. And throughout your care plan, it's always good to mention that. Say, you know what, Bob, you're doing great on these. We're gonna maintain this later. I can't wait to get you into the wellness visits where you can just come in and relax and enjoy this, and we don't have to do all this at-home stuff. You're gonna love this. And I got to tell you, people when they would go through that in our clinic, they didn't want to leave. That became a great thing, coming multiple times. And when we told them they're going to start coming, once every other month, once a month, or even twice a month, they didn't like that. They wanted to keep coming. This was their outlet. They loved it. So you're going to experience that too. So keep that in mind. Even though some of them, they still have a condition that may linger with them and become chronic, that's fine. Then you can still transition into wellness, and they can still be a very well person in spite of a condition. Okay? Now, just a lot of you guys haven't taken my research course. Why is research important? It's because it shows that we're up to date. Things change. People are developing new ways, new methods. They're discovering new things about the body even. We've only scratched the surface. So you got to get up with some research. So what's some of the best things to do this? Well, first of all, or why do you need this? You have to have be able to clearly identify practice, problem, or new knowledge. Okay, research will help you do this. Innovation. You have to be able to sift through and find good research, literature. I think I got some links in here too. Then you have to know how to evaluate a research paper. You got to know if it's actually done right. If it was a single blind, double blind, or no blind. Was it biased? You got to do that. Then you have to be able to apply to the practice through the change of process, which is what we're going to be transitioning to a evidence-based practice. So this is all going to lead into this. Couple of the places that you can get some research is, I'm not going to even try to read all those URL links. They're here. Okay, you have this on recording, so write them down. So that will be a good place to start. You guys aren't going into research. I don't think anyone in the class has explicitly wanted to do that or expressed that to me. So this is a good thing right here to use. These two right here, and I think there's even a third. Yeah, there's another one right here, Foundation for Massage Therapy. Of those three, you should be able to keep up to date and very well informed on just about everything with the profession. Now, some of you guys are already looking for that, don't want to wait for the module. Basically, this is what a research article will have. It'll have location, title, background, the purpose, methods, results, discussion or conclusion, and references and works cited, okay? So, you're going to have the title, where it's located, right? You're going to have the background. Why are they doing the research? What was this done? And then that was the research. Now, what's the purpose of redoing the research? Or what's the purpose of this research article? Then how did we do it? What was the conditions like? What was the environment for the research? Where did it take place? What were the people or the subjects? That would be this. Then after all that, hey, what's the results? This is the empirical data that we obtained from this. Great. This here's the analysis part. It tells you what they did. Now this is the author or the research person's, hey, what's your thoughts on it? Did it fly? Did it swim? Did it sink? Was it good? Was it bad? Did we botch the whole experiment? This is their personal thoughts. Okay? So a lot of times people will just go ahead and read the conclusions pretty quick and see what it was. So, whenever I'm looking through, and I'll get more later into the research thing, but a lot of times I would just look at the purpose. Why are we doing this? And if it's something that intrigued me, then I would do it. Then the next thing I'd look at the conclusion. And if both those matched, then I would take my time and read the whole thing and see. So that's the basics of a research article and what each one of those things mean when you're reading the paperwork. So let's have fun. Let's do a little case presentation of why we want to go evidence-based practice and what type of patients we may see coming in. So here's just an example. 45-year-old female with right shoulder and neck pain and hand numbness. So she has some stuff going on in her neck. It's going down in her shoulder and going down into their hand. Now, you anatomists out there are already probably thinking double crush or some type of plexus lesion going on. That you're probably right. Now, it really exacerbates by external rotation and abduction of the shoulder. So what are we doing? We're really stretching the pec minors and majors, the anterior scalenes, the SCMs. We're stretching all those. So are we crimping possibly the plexus in this? Okay. We may have an entrapment syndrome, maybe a toss. Well, what does she do for a living? Computer worker. Great. So she sits at a desk with the anterior head carriage 9 times out of 10, right? What caused this to happen? Oh, she was in a motor vehicle accident 8 days ago and hit from behind. Okay, so what did they do? Well, they prescribed muscle relaxants and pain meds at the ER. Great. We didn't treat anything. We just calmed her symptoms down and got her out of our hair. Okay. Now, she had a VAS, visual analog scale, from an 8 out of 10. 0 is being no pain at all. 10 is like emergency room. So she was pretty hurting. She went to the chiropractor who referred to us. Now, the diagnosis from the chiropractor is a thoracic outlet syndrome patient post-motor vehicle accident. So, thoracic outlet syndrome, so we're having something that's occluding the outlet, causing impingement, possible, so we have a whiplash case right here. Is what we're doing with more exacerbation on the right side. So what's happening, the chiropractor or the treating doctor should have asked if they were the driver or passenger. Or you may even ask that. Why is that relevant? Because if you're the driver, the seatbelt's going to go over the left shoulder and it's going to hold you firm and it will make the right shoulder whip forward. If you're the passenger, it'll go over the right shoulder and controversially it will make the left whip forward and you can get a rotational type strain and injury from this. And I guess the first question would be, were you wearing a seatbelt or not, right? So then you can ask if you're in the front, left, front, right, or in the back. And you can kind of play into that. And I think we have a whole webinar that's going to be in this course on whiplash where we'll go into that in detail. So that's the kind of case that's going to be presented to you. So what are you going to do? What might we do? Well, we're going to learn about this in Mod 2. We may do our own cervical range of motion. And here's the thing. The doctor, chiro, naturopath, physical therapist, medical doctor, osteopath, they're all going to do an exam. And they're all going to do a basic orthopedic test on these. You're going to ask for their notes, their physical exam, and they're going to tell you what they found. I recommend you doing them just to have your own base, because say if we do a cervical range of motion, we have Mary sit in the chair. We get behind her and say, all right, Mary, flex your head as far as you can and tell me when it starts to hurt. How about turn left and right? Tell me when it starts to hurt. Even though the other doctor did that, it's not a bad idea for you to do that for your own record keeping and your own tracking of the condition. So say she can only bend like 10 degrees or only rotate about 5 degrees and only look left 5 degrees before it starts to hurt. Okay? We may do a cervical compression, maybe a distraction. We're going to go into these in Mod 2, what these are. Maybe a shoulder depression. We're also going to do a VAS scale. That's going to be our base because she just came in and we got our base and we're going to see if it matches with the doctor's. What happens if it's worse than the doctor's? That tells you the patient is on a decline. They're getting worse, so we got to get them in right away. Would you share that with the patient? Absolutely. Mary, you seen Dr. Smith last Friday. Here it is this Wednesday, and you're coming in, and you've actually lost range of motion. Your actually pain scale's going up. This test wasn't shown, but man, now it's positive. It's causing problems. So we need to get you in here. We need to get you going. It creates a sense of urgency, and it also shows that you really know what the hell you're talking about. Okay? Are you diagnosing? Absolutely not. Are you making an assessment for your own records to see if what you're doing is making a difference and gives you a position of monitoring? Yeah, that's what you're doing. Okay? We're not diagnosing. Now, what about a care plan for this person? If all these came back positive, a simple care plan that we're going to be leading into. During the first month, they may receive MMN care for 3 times a week for 30 minutes for the first 2 weeks. Then 2 times a week for 30 minutes for the first week. Then break them down to an hour for once a week for 2 weeks. Then an hour for 2 a month for 2 months. And then you go on maintenance. So say if you get him to this stage here, and obviously what you should be seeing as the care plan gets more spread out and frequency decreases, you should see these things start dropping off. She's no longer positive for a distraction, no longer positive for a compression. Her range of motion is increasing with all of our visits. Okay, so do you have to go for 2 weeks? What if Mary's doing so good, she's back to normal? Well, don't do it for 2 weeks. Just do 1 hour care for 1 week. Forget the other one and go right to a month. Skip a or 2 month. Skip a week. Okay. That's what I mean by having it dynamic. This is just an estimate. Now, whenever you come up with a care plan, the patient's going to have some concerns and have some type of a backup what you're going to tell them. What about the care plan? What about the money? Well, normally we charge $60 for an hour, so guess what? You're still going to do the $60, but we're going to break it up into 2 half-hour segments. So the money's going to be the same. Or we're going to submit it to your auto carrier insurance and have them pay for it. I took a course with Dr. Hawley, and Marty Kotler is an insurance specialist. He came on and spent a whole hour and told me how to bill it. So guess what? We're going to bill it now. Okay? So always address that. You may even work up a care plan, a special price for the whole thing. So yep, it's going to cost $500 here, and we're going to submit all our notes to you, and we'll give you all of our bills, and you pay us, and you can submit the super bill to your insurance carrier and show them what we've did. And maybe they'll pay you, maybe they won't. Either way, my goal is to get you better. Do something like that. Okay? Again, you're going to have goals, undisturbed sleeping, be able to walk, and maintain normal cervical range of motion. Now, here's a key thing, too. Once the client can assume normal range of motion, move their head all over without an increase in pain, then you can start having them do at-home exercises and some things like that, and some stretching to really even strengthen the gains that you made with them. Okay? You can also print out a list of at-home instructions. Do ice for 10 minutes and heat for 10 minutes. Alternate them back and forth at least 3 times if it's really sore one evening. Or stretch, or some kinesiotaping. Things like that, okay? Now, soap. A lot of you guys aren't familiar with soaps. Some of you are. Depends on what schools you went to, how long you've been out, and what you're looking for. We never get away from the soap notes. This year, I'm not going to read all this. You guys probably know all this, but just a refresher, soap is for subjective. What they tell you, okay? That's what the client's going to be telling you, and on each visit. Now, the O is for the objective, what you actually seen, what you palpated, what you felt, what you noticed. Now, the assessment, this here is going to be, what you've seen at the end of your treatment. We did this, and this is how the patient responded, and man, they walked out feeling great, like $1,000,000. Had some more range of motion, and they weren't limping when they walked out. The plan, this here is going to be the plan. We're going to continue with recommended plan in the initial evaluation. We're going to alter this. Patient is doing so well, we're going to not see him 2 times this week. We're only going to see him once this week, and then reeval next week. That's going to be your plan. Okay, you need to have that so you can keep track of everything. Now, notes. Some of the notes that you may be taking. What are you going to be looking for an MMT? Patient states in a subjective, they've been getting intermittent headaches on it and upper back spasms throughout the day, but treatment seems to be helping and take the edge off. That would be a great subjective there. Some things that you've noticed, patient presents with higher right shoulder with moderate taut and tender fibers with palpable trigger points in the upper traps. The lower lumbar, mainly on the left side, is guarded but not hurting. So what are they doing? They're starting to get a cross pattern going on with the other parts of the body. So you may need to address that and build that into the plan. Okay, that's an idea of how your notes will be reading. Ortho and neuro. So say myofascial release on the neck and shoulder. Ortho and neuro tests. So say these right here is where those would go. That's kind of, we had a positive cervical compression test. Cervical range of motion showed an increase of range of motion without pain today on flexion. Patient gained another 10 degrees flexion after our muscle stripping in the suboccipital area yesterday. Patient is loving treatment. Things like that. That's where all those will go. So you may be writing about the ortho neuros. MMR, myofascial release, or MFR, myofascial release to the neck, shoulder and chest for 30 minutes. Tell what you did. And afterwards, hey, patient gained more range of motion. Went from an 8 down to a 4. Woohoo! We're decreasing pain and increasing range of motion. So there's a number of things you can do. And also you can tell what they've did with at home. Say Mary was feeling so much better today, we told her take it off tonight. Don't worry about it. Or Bob was really tight on the right today in his upper back and neck. So we did some stretching, some passive stretching, and we gave him an at-home instruction to stretch 2 more times in the manner in which we showed him in the office. We'll see him next Thursday to reevaluate. That's very applicable on how we would do that. So that there, I believe, gives you an idea of what the evidence-based massage is going to be looking like and condition-based, and how it is different from just general wellness and some of the things, and how you're going to be learning to take notes, some of the tests. And I think we're going to be going through a bunch of ortho tests next week, or next module as well. So that is what we're going to be doing throughout this whole course, and it's going to be geared toward setting up this style of practice and training. So anyways, I wanted to give this to you. I will sign off here, and we will be talking very soon, and we'll see you in Module 2. Take care. This is Dr. Hawley. Have a good one.